In the next section, we will cover some case reviews. In this section, we'll go through some case reviews. Now that we've learned all our immunology, let's put it to some use. Case number 1. A 32-year-old male presents to your ER with severe shortness of breath and a very red rash all over his body. The patient has a known allergy to nuts. On examination, you find the patient hypotensive, tachycardic, with bluing around the lips and face. You also note a wheezing coming from the patient's throat as he fights for breath. You remove the patient's shirt, and you notice numerous round, raised, red rashes. What's going on here? This is anaphylaxis, right? He's got a known allergy to nuts. He comes in short of breath. He's hypotensive, tachycardic. He's got bluing, cyanosis in the lips and the face, and he's wheezing. So he's got anaphylaxis. He's got these round, raised, red rashes. What are those? Those are hives, right? Characteristic of an allergic type response. So what are you going to do? First of all, ABC is trauma, right? You've got to protect his airway and his breathing, circulation. You're going to make sure that he's stable. In the process, you're going to give him some epinephrine. You're going to help try to fight the processes of anaphylaxis that are going on. And then you're going to make sure that the next time he leaves the hospital, he leaves with an EpiPen. Case number 2. An 18-month-old male infant presents to his pediatrician for a diaper rash that does not improve with normal diaper creams, despite the fact that his mother changes his diapers frequently. The patient has also suffered numerous furuncles requiring incision and drainage. The mother is perplexed and comes to you to help her fix her child. The diaper rash is very discomforting to the patient and his mother. On physical exam, you note the patient to have a severe candidal infection of the diaper with satellite lesions. You also notice several scars on his legs from where previous boils have been drained. There are also 2 to 3 fully formed pustulating boils on his legs. What is going on? What are you going to do? So here we have some different characteristics, things that are important to point out and notice. He's a boy, right? First thing, he's got these recurrent furuncles that require IND, so he's getting these skin abscesses, right? He's got this bad diaper rash with candida infection, scars from previous boils. So he's getting repeated skin infections, and he's got candidiasis. So what are you thinking here? Lots of possibilities, right? This could be some type of T-cell chronic mucocutaneous candidiasis picture. This could be some type of B-cell defect where he's getting skin abscesses. This could be some type of phagocyte deficiency as well. So what would you like to do to distinguish this? You're going to take a CBC, you're going to look at some tests, you're probably going to run an NBT, right? Maybe do some flow cytometry. So, moving on, let's say you do all these things. The patient's blood is found to have neutrophilia leukocytosis. The NBT test remains yellow. Flow cytometry assay is negative. So what's your answer? There's your diagnostic right there. This is CGD. NBT test doesn't change. NADPH oxidase is not working. This child has CGD. What are you going to do? Antibiotics. You're going to give him antibiotics, right? And you're going to treat his abscess. Case number 3. A 10-year-old girl presents with severe dyspnea and diffuse subcutaneous painful swelling of her hands, feet, and face after visiting the dentist. Her chest x-ray is normal, and her dyspnea was apparently due to laryngeal edema. Her mother has a history of similar symptoms. What is going on? What would you do? So here, we have a girl, minor traumatic event, now she's swelling, family history. What are you thinking? Hereditary angioedema, right? All the characteristics are there. So what are you going to do for her? You're going to help treat the swelling. You're going to counsel. You probably do some genetic testing, see where the defect is. Most likely C1 inhibitor deficiency, right? And then you can counsel. Case number 4. 26-year-old man has a history of chronic otitis media, mostly strep pneumo and H. flu, recurrent sinusitis with strep pneumo and H. flu, and recurrent watery diarrhea from Giardia. He was admitted to the hospital for pneumonia. He is allergic to pollen, latex, wasp venom, and shellfish, and has received desensitization shots from his rheumatologist. He also has celiac disease. What is going on? Well, we've got recurrent bacterial infections, chronic bacterial infections like otitis and sinusitis, so that's going to point us where? B-cell deficiency, right? Recurrent watery diarrhea, enteric infections. He's allergic to pollen, latex, wasp venom, and shellfish. Why is that important? indicates that he has B cell function, right? He has hypersensitivity reactions. He's got celiac disease, again pointing to that mucosal type of lining. So what is going on? IgA deficiency, right? What would you do? You're going to treat his infections. In case number 5, a follow-up, the younger brother of the previous patient has become fatigued with excessive thirst. Laboratory studies show an elevated fasting glucose. What's going on here? Diabetes, right? Polydipsia, polyuria, elevated fasting glucose. Is there a relationship with the brother's disease? Possibly. Actually, there's a good chance that there is. A lot of these autoimmune diseases run familial, even if they're different autoimmune diseases. Case number 6. A 5-month-old male infant has mucocutaneous candidiasis, diarrhea, and is not growing. Recently, he developed Pseudomonas pneumonia and septicemia and died. An autopsy was requested to determine the cause of death and apparent immunodeficiency. Of note, the decedent had a paternal cousin that died of a similar process. His premortem peripheral blood smear was remarkable for complete lymphoid aplasia. Premortem skin tests for delayed type 4 hypersensitivity reactions were negative, and IgG, IgM, and IgA were all low. He does not have visible tonsils or palpable lymph nodes, and there are no lymphocytes in the lymph nodes, spleen, tonsils, and appendix. The thymus is undescended and found in the neck. It resembles the thymus of a 6 to 8 week gestation. Red blood cell enzymatic studies are pending. What's going on? Well, 5-month-old male, opportunistic infection, Pseudomonas, right? Premortem peripheral blood was showed complete lymphoid aplasia, so he had no lymphocytes. He had no hypersensitivity reactions, no antibodies present, no visible tonsils, no lymphocytes in any of the secondary lymphoid tissues, and an undescended thymus. SCID, right? This is classic. This has all of the characteristics that you would note in a boy with SCID. The red blood cell enzymatic studies, what are those looking for? ADA, right? So what are you going to do here? Well, for this patient, unfortunately, he's passed away. You can't do anything. If he were still alive, you could give him antibiotics, keep him isolated, and do a bone marrow transplant. As far as this family is concerned, you want to discover what caused this patient's SCID and then offer genetic counseling to the parents. Case number 7, a 47-year-old diabetic woman who had a kidney transplant 2 weeks ago presents with shortness of breath, hypertension, rapid weight gain, orthopnea, and oliguria. She is taking cyclophosphamide for immunosuppression. Her blood pressure is currently 190/105, heart rate 85, respiratory rate 22. Edema is noted. CBC is within normal limits, elevated serum potassium and creatinine. Urine protein was 3+, and blood cultures are negative. So what's going on here? This is kidney transplant rejection, right? What type of rejection? 2 weeks ago, you're thinking acute, right? That's long enough. This is acute, not hyperacute. What are you going to do? She's already on immunosuppressive therapies, so we could try increasing that dose. We could try adding a second drug, or we could try changing drugs altogether. Other things that you're going to want to consider are obviously putting her back on the transplant list, because there's a good chance that this organ is going to fail, and making sure that her other symptoms are treated. This concludes our case review section, as well as the immunology lecture series for Step 1 USMLE.